Let's Talk Lungs with Trent and Lori from Lung Saskatchewan. Dedicated to connecting you with lung health experts and key opinion leaders who will share current, evidence-based lung health information to inspire you and those you care for to take your best breath. This podcast is recorded on Treaty 6 territory, the ancestral and traditional territory of the Cree, Dene, Blackfoot, Saulteaux, Nakota Sioux, as well as the territory of the Métis.
On this episode of Let's Talk Lungs, we are delighted to welcome Dr. Connie Yang. Dr. Yang is a pediatric respirologist and researcher at the Hospital for Sick Children, where she is the medical director of their asthma program and the scientific director of the Ontario Asthma Surveillance Information System. She has participated in the development of multiple provincial and national asthma guidelines, and her research interest is in identifying children who are at risk of poor asthma outcomes with the goal of providing more targeted treatments.
This episode of Let's Talk Lungs is sponsored by GSK. GSK is a global biopharma company with the ambition and purpose to unite science, technology, and talent to get ahead of disease together. Thank you, GSK, for partnering with us in bringing this episode to our listeners and followers. Dr. Yang, thanks for making time to have a conversation with us on our show today. We know you are passionate about the lung health of our little people and that your research has focused on finding the best way to diagnose and treat different types of asthma. Like the title for this episode suggests, we were particularly interested in learning about where science is taking us. Maybe learning more about why some children have severe or have treatment-resistant asthma, and what we are learning about treating these children effectively, where the science is guiding us. So Dr. Yang, before we dive into all things asthma, tell us a little bit more about you. Why medicine as a career? Why this specialty in pediatric respirology?
Thanks for inviting me to be on the show. So first, to start, I guess, why a career in medicine? To be honest, I was somebody who liked science, and I was lucky to be encouraged, gently, shall we say, to think about a career in medicine by my mother, which did actually turn out to be one of the best decisions that I've ever made because I do love what I get to do every day. I chose pediatric respirology because when I was learning how to be a pediatrician, I realized that breathing problems overall are incredibly common in kids, and when they happen, they're very scary for families. And I also realized that having chronic breathing problems really gets in the way of how kids get to lead their lives. And so for, I think, those of us who have never really had problems with our lungs, we take for granted that you never have to think about your breathing. And so I really wanted a job where my goal was to help kids kind of be kids without having to worry about their breathing getting in the way. And I'd say the other thing I really like about pediatric respirology is that we're always trying to fix the problems of today, but also we always have a mind to sort of the future of what's going on. And we're always trying to optimize lung health for our patients so they can be healthy adults who also don't have to worry about their breathing.
Well, it certainly sounds like your mom has pointed you in the right direction, Dr. Yang. So for those listening that might not know entirely what asthma is, can you give us the Coles notes on what asthma is, what symptoms are, and how it's diagnosed in children?
Yeah, so I think of asthma as really a problem of the smaller airways in the lungs, and there are really two issues that cause asthma symptoms. The first is inflammation, which is our fancy way of saying swelling or irritation, and the second is that the airways are too twitchy, which means that airways are really prone to tightening up or going into spasm when they get irritated. And so really it's both of these things that lead to your airways getting narrowed, and that's what actually leads to asthma symptoms. In kids, the thing that really makes us think about asthma is wheezing. And when we say wheezing, what we specifically mean is that high-pitched kind of whistling noise that comes from the lungs. And it happens usually when you breathe out. And that's a sign that your airways are a little bit narrow. Other symptoms of asthma can include things like shortness of breath or chest tightness or coughing, which in asthma is typically like an ongoing cough and usually a fairly dry cough in kids. To the second part of your question, really the way we diagnose asthma in kids depends on how old they are. So for all kids, no matter how old they are, the most important part is that the way we diagnose kids with asthma really depends on how old they are. So for kids of any age, the most important part is that the history or the story of their symptoms is consistent with asthma. Then for kids that are actually able to do breathing tests, which usually is kids over the age of 6, we really like to see that their breathing tests show signs of those narrowed airways that improve after they get asthma medicine. In younger kids, so preschoolers or toddlers, we really don't have breathing tests that we clinically use right now that help us to diagnose asthma. So we really rely on the story of their symptoms. how their lungs sound when they're having those symptoms, and if these things get better with asthma medicine.
So how common is asthma in children? And has this changed over time? Because when I was a child, the word asthma was floated around very, very minimally. And a two-part question for you. Are more children now being diagnosed with asthma, or vice versa? Are less being diagnosed?
Yeah, so there's about 15%, which is a lot of kids in Canada that have asthma. It is the most common chronic lung disease of kids. And I'd say over the last 20 years, there have actually been fewer children overall that are being diagnosed with asthma. I would say the COVID-19 pandemic threw a bit of a wrench in the statistics, because in 2020, we really saw, because everyone was isolated and kids were overall getting fewer viruses, we really saw less kids getting diagnosed with asthma. And then post-pandemic, we saw a spike of new asthma cases. And this year, actually, we're going to be looking at our Ontario post-pandemic data to understand if where we are right now is sort of the trajectory we're on before COVID, or if we're still seeing an increased number of kids being diagnosed with asthma.
Dr. Yang, is there a difference in how prevalent asthma is among boys and girls?
Yeah, there is. And it really depends on age. So in younger kids, before they reach puberty, asthma is actually more common and more severe in boys. And then after puberty, it's much more common and more severe in girls. And this is somehow linked to hormonal changes that are happening during puberty in girls, which really is sort of still an area that people are researching.
Well, Dr. Yang, we've been talking about symptoms and how asthma is diagnosed, but do we know what causes asthma in children, and what is the science telling us?
So I think the science is telling us, and maybe it's been pointing us in this direction for a while, that asthma is probably lots of different kinds of diseases. So, we talk about asthma, but actually there's many different kinds of asthma. And trying to untangle what causes asthma is challenging, because it depends on the kind of asthma that you have. So what we know is that definitely there's a genetic part and an environmental part that play a role in what makes kids actually have asthma. And so we know kids who have a family history of asthma or allergic conditions are more likely to get asthma. So we know that's a big factor. But as opposed to other lung diseases like we see, like cystic fibrosis, for example, where the genetics are very straightforward, in asthma, there isn't a single gene or a combination of genes that reliably predicts who's going to have asthma. And I think we know that's because in addition to having this genetic predisposition, there are these environmental triggers that unmask people's asthma. And so, for example, we talked a little bit about allergic conditions, but we know kids who have eczema or food allergies are more likely to get asthma. And I'd say some of the most interesting research over the last 10 years is looking at the role of the microbiome in the development of asthma, which has helped us explain why, for example, kids who are breastfed are less likely to get asthma, or why kids who get antibiotics as infants are more likely to get asthma.
So can we dig a little bit further into that? And are some children then more prone to asthma than others? And if so, why?
Yeah, so there are definitely risk factors for developing asthma in kids, and the most common one that we tend to think about is having allergic conditions, eczema, food allergies. Another risk factor for developing a type of asthma is being born prematurely or too early. However, lots of kids with asthma, and particularly those under the age of 5, don't really have either of these risk factors. So I think, to be fair, we're still understanding what the risk factors are for all those different kinds of asthma.
Dr. Yang, we hear a lot about the importance of maintaining good asthma control. And for someone living with or caring for someone with asthma, what does that really mean?
So I tend to think of asthma control as 3 separate but related things. So the first that everybody tends to think about is asthma symptoms. The second is asthma attacks. And in older kids, the last thing is lung function that we measure with a test called spirometry. So in a nutshell, for us, good asthma control really means that you have very infrequent to no asthma symptoms. You don't have any asthma attacks that require oral steroids or emergency department visits, and you have normal lung function. And I think for kids, we always want to stress that part of good asthma control means that they can exercise as much as they want to without their asthma limiting them. I think it's always a bit heartbreaking to hear in clinic that families will actually limit how much they let their kids play or exercise because they're worried about their asthma or they don't want them to have to take asthma medication. And we're always trying to remind people that good asthma control means that you should be able to exercise with no issues at all. And I think as pediatric respirologists, we're slightly obsessed with making sure kids have normal lung function. function, because we do know that whatever lung capacity kids have really sticks with them into adulthood. And as adults, our lung function will naturally decline with age. So we want to make sure we build up as much lung function as we can with kids. So I'd say that's why, as much as people think of asthma control as asthma symptoms, we're always really thinking about not only symptoms, but also asthma attacks and lung function.
Well, now let's shift our conversation a little bit and let's talk a little bit about asthma severity. Like, why do some children have more severe asthma or asthma that is more difficult to treat?
First, I think it's important to talk a little bit about the difference between asthma that's more difficult to treat or difficult to control and what we think about as severe therapy-resistant asthma. And so when we think of severe sort of therapy-resistant asthma, we think about kids who are on very high doses of asthma medication every day and still not getting good asthma control. And we've really made sure that they're taking their medication every day with the right technique and that we've treated as best as we can everything that we know makes asthma worse or the things that can cause symptoms that really seem like asthma. And I'd say difficult to treat or difficult to control asthma means that we really aren't getting your asthma under control with typical management. But because not all of these patients have had the chance to fully understand their asthma and what their treatment entails, I would say the most common reason we see for difficult to treat asthma is that kids aren't taking their medication every day for a variety of reasons. So back to your original question of why some kids have more severe asthma, to be honest, we don't really know. I'd say the research on this is still ongoing because when we compare studies of kids who have severe asthma to kids who have more mild asthma, we really haven't found the reason that the kids actually are being prone to that more severe asthma. So for example, we know that most kids with severe asthma have allergic asthma or T2 high inflammation asthma, but we can also see that pattern in kids with milder asthma. So I think there's a lot of work that still needs to be done to figure out who actually is going to develop severe asthma.
Well, we are going to take a short break and get right back to our conversation with Dr. Connie Yang.
Lung Saskatchewan has long been associated with leadership in lung health education. Whether you enjoy webinars, videos, printed resources, or podcasts like this one, we're here to support your best breath. Learn more at lungsask.ca.
Welcome back, listeners. We are talking with pediatric respirologist Dr. Connie Yang about asthma and just finished learning about what good control of asthma is. Dr. Yang, we know that there are some changes recently, both Canadian and international guidelines on the diagnosis and treatment of asthma. Tell us a little bit more about that. What is science telling us about the management of asthma now versus 5 or 10 years ago?
Yeah, so over the last few years, I'd say the biggest changes for pediatric asthma is first agreeing as a community how we should diagnose and treat asthma in kids under the age of 6, which is so important because we know this age group has the highest rate of emergency department visits and hospitalizations for asthma. And I think for a long time, and to be fair, I still hear this from families who have been told that we can't diagnose asthma in kids who are younger than 6 or until they can do lung function tests, which really isn't true. And I think something that we can be proud of as Canadians is that really the international guidelines are starting to mirror what our Canadian guidelines have been saying for the last 10 years on this topic. The second big change is really understanding the importance of having anti-inflammatory medication as part of the asthma treatment plan, really for the vast majority of patients with asthma, and really starting to understand about the dangers of using too much reliever medication for asthma. So, for example, 5 or 10 years ago, people used to say that if you used more than one blue inhaler a month, you were at risk for having asthma attacks. And now we really know that number is much lower and that people who are using 2 or more reliever inhalers in a whole year are actually at higher risk for asthma attacks. And so really there have been a lot of studies looking at replacing the usual blue reliever inhaler that everyone is so familiar with inhalers that combine both a reliever and some type of anti-inflammatory medication, typically an inhaled steroid. And although these studies have really happened mostly in kids over the age of 12 and adults, and that has led to new recommendation in those age groups, I'd say in the future, I think we're starting to see more of these studies being done in younger kids. So I think we might see some of those changes trickle down to younger kids as well. And I'd say the last change, and maybe this is particularly in the adult asthma world, is really recognizing that even short courses of oral or IV steroids do have side effects. There's studies in adults that show even 4 lifetime courses of oral steroids can have detrimental side effects. And so I think in kids, our goal has always been on preventing asthma attacks and really trying not to use any oral steroids or IV steroids. for asthma attacks unless it's absolutely necessary. But I do think it helps us provide guidance for families that still think that, 1 or 2 courses of oral steroids a year is good asthma control and is somehow safer than perhaps a daily low dose of inhaled steroids.
Dr. Yang, it's apparently clear that asthma treatment is certainly not a one-size-fits-all. So can you help us understand how science is changing treatment for kids with more severe asthma? We're hearing more and more about biologic therapies for asthma, for example. So can you start with helping us understand what a biologic therapy is?
Yeah, so generally, a biologic therapy is a medication that very specifically targets part of the immune system, and typically it's given by injection. So, for a long time in pediatric asthma, we only had one biologic, which was omalizumab, and that one has actually been around for about 20 years. And now we have 4 different biologics that are approved to be used in kids with severe asthma.
So then who would be a candidate for trying biologic therapy?
Yeah, so we tend to reserve biologic treatment for kids who are over the age of 6, because that's where the studies have been done, who are on high doses of asthma medicine, usually an inhaled steroid and a long acting reliever, who still have poor asthma control. Or they're on all of that medication and we can't wean them off that medication because every time we try and drop the dose, they have more poorly controlled asthma. As we've talked about, we always go through a whole process. I think of it as a bit of an asthma boot camp to make sure we've really fixed everything that is fixable before we start somebody on a biologic, because it does involve needles, which, to be honest, most kids are not a huge fan of, and they can be as frequent as every 2 to 4 weeks. And for families that don't have private insurance, it can be quite costly because not all of the biologics that are approved in Canada for kids are actually available, depending on what province you live in.
Is biologic therapy then considered a lifetime treatment?
So interestingly, in kids, it really isn't considered a lifetime treatment, but I'd say, which kids can and can't come off biologics is an area of really active research. So some studies have shown that when kids who have severe asthma are followed over 3 years, only half of them still have severe asthma by the end of that follow-up. So I think in kids, we do consider discontinuing biologics if they've been well controlled for a couple of years, but the timing is very individual because it really depends on why the biologic got started and how that child is actually doing since they've started the biologic.
Dr. Yang, we are starting to hear the terminology asthma remission, and we've heard that term associated with cancer, but it's new for us to hear for something like asthma. What is asthma remission?
Yeah, so it's so interesting because the idea of remission actually isn't that new in pediatric asthma. One of the most common questions that I hear every day from parents is whether their kids will outgrow their asthma. And parents often tell us, that they used to have childhood asthma, which they then outgrew. And in some senses, this is kind of what remission is. I'd say the term remission is probably more accurate than outgrowing asthma, because we know that even in kids who have no asthma symptoms for many years off medication, those symptoms sometimes do come back in adulthood. So in a sense, like even when kids are off treatment, we know symptoms can come back. So I'd say what is newer is this concept of remission on treatment. And so this is a concept that I think really applies more to kids who have more severe asthma, because that group of kids, we really never thought that they would outgrow their asthma symptoms. But I think now with the new biologic medications that we've been talking about, we're seeing that these kids who have quite severe asthma can essentially have perfectly controlled asthma with no symptoms or asthma attacks and totally normal lung function while they're on that treatment.
Well, we're getting to the end of our time together, but can you talk to us a little bit about the direction research is going right now for asthma, both in terms of drug and non-drug treatments?
Yeah, so there's so much exciting new treatment options in terms of new medications in the pipeline for asthma that are looking at lots of different inflammatory pathways. But I would say those are probably largely focused on kids with more severe asthma. Another huge unmet need that we have that is starting to get more research interest is the use of biologics in children under the age of 6, which is a group of kids that we currently don't have any approved biologics for. I think for children with any kind of asthma, we're really starting to focus research on how to be more precise with our asthma treatments, really by identifying the root causes of the symptoms or the asthma attacks. And hopefully with that, we can sort of start to become a little bit more precise with the treatments that we offer. From a non-drug perspective, I think there's exciting studies that are being done to prevent asthma from even developing in kids who are at high risk for getting asthma. And we've seen this with studies that are trying to change the microbiome and studies that are starting to come out looking at the new RSV vaccines, which I think you guys have talked about on another program. And that'll be interesting to sort of see if some of those vaccines and antibodies actually prevent kids from even getting asthma in the first place.
Well, Dr. Yang, throughout this conversation, we hear two things. We hear passion, we hear hope. We know you don't have a crystal ball, but do you think with the direction research is going, we might find a cure for asthma?
I will say I'm a pragmatist at heart, so I kind of find it difficult to envision, given how complex and varied the underlying reasons are for asthma, that we're going to have a one-size-fits-all cure. But definitely, I think asthma remission on treatment is a realistic near-goal future for many kids with severe asthma, and I think precision medicine is definitely a realistic goal for many kids with asthma. And I probably, in terms of, a true cure, I'd place really high hopes on research that's looking at preventing kids from even getting asthma as probably a good direction that we're headed in.
Well, Dr. Yang, thank you so much for being with us on Let's Talk Lungs. We're deeply grateful for the passion and care you bring to your work, helping children with asthma breathe easier and giving families hope through your research and leadership. The impact of your dedication reaches far beyond the walls of the clinic or the lab. We hear that, and we're honored you took the time to share your insights and heart with us today. Thank you.
Thank you so much.
Thanks for listening. If you enjoyed this episode and you'd like to help support LungSask's Let's Talk Lungs podcast, please share it with others. Post about it on social media. Like, subscribe, hit that notification bell for new episodes, and leave us a review. Follow LungSask on Instagram @LungSask and on X @LungSask. That's all for this episode. See you next time.
Produced at
Sound Lounge by T-Bone.